So without further ado, I'm introducing Ian Backlund, one of our star PGY-3s, who will be talking about Charlottesville.
Hey guys,
Go
thanks
ahead.
for tuning in. Yeah, I'm gonna try to share my screen here.
I bet you can do it.
Let's do it. Let's try.
Ian's down in Roanoke right now doing a Roanoke rotation. I just want to give a quick shout out to next week. We're going to be talking about the Roanoke rotation next week with Dr. Ted Schuler, who's our program director down there. I think as far as applicants go, the kind of like the thing we don't know too much about is Roanoke. When you're an applicant, you see UVA and you can kind of see all the faculty here, and then Roanoke ends up being this kind of different place that we rotate at. I think next week will be really helpful as far as helping you understand what Roanoke's all about. But Ian's down there right now, and so again, Ian, thank you for being here, and go ahead with your tour of Charlottesville.
Absolutely. Yeah. Can you guys hear me okay? Awesome. So again, I'm Ian Backlund, one of the PGY-3s here at UVA orthopedics residency. So excited to give you guys a talk on Charlottesville, Virginia, kind of life outside the hospital. I appreciate you guys tuning in for your busy schedules as well. So thanks for learning a little bit about our program and where we do our business. So Charlottesville is an awesome place to live. So I think, as Dr. Wathy may have said in previous lectures, it really is kind of a Goldilocks phenomenon. So it's a small town, but it really has some big town accommodations, which is very cool and sort of lends itself to being appealing for a lot of people. I'll get into some of the nuts and bolts of that, but this is kind of an aerial shot of the end of the downtown mall, one of the outdoor arenas where there's some concerts, and we have a lot of, again, bigger venues, and for people who like the smaller town feel, have accommodations for that as well, which we'll get into. But you don't have to take my biased opinion. Charlottesville is a top-ranked city, so there's some of the sort of acknowledgments in many magazines, as you can see, for many, many years listed very high on some of the happiest places to live. And so it really is an awesome place to spend 5 years of residency, and a lot of people end up sort of putting down roots here, which I think really speaks to how awesome of a town it is. But we'll get into a little bit of that. So for those of you who aren't familiar with Virginia, so obviously a map of Virginia, Charlottesville is sort of in the sort of northeastern aspect of the state, and we're pretty close proximity to some big cities, both Washington, D.C. So it's a 2-hour and 19-minute drive to D.C., and then a little bit over an hour to Richmond, which both have even bigger accommodations. So well within reach for some of the bigger city accommodations if you want to get away, as well as the beach being within a weekend trip as well. So one of the things I really like about Charlottesville is the weather and the seasons that we have here. You see, depending on what climate you guys are coming from, really has a kind of a nice spread in terms of going through the season. So again, about 87.5 is our high for our hottest month in July. But we average about 219 days of sunshine a year. So it's an awesome place, usually pretty good weather for the most part. Sort of the average rainfall there. And then we have a couple of snow days a year, which are pretty short-lived. Usually it's melted off by the following day, but it's still kind of fun to see it every once in a while if you're coming from some of the hotter climates and some of our accumulation there. But it doesn't tend to interfere with our life very much, which is important because you're coming and going from the hospital a good bit. But again, as I sort of alluded to, the seasons really are an awesome sight to see here. So as we're sort of approaching this now, some of the fall foliage and the colors that come in, a nice break in sort of the change in weather as we get into some of the cooler months of the year. And it really is a sight to behold. This is an aerial picture of the grounds. And again, you can see some of the vibrant colors coming in. And they actually release sort of information on when the peak days for foliage are, so you can go to the mountains, and people come from pretty far around to go up in the mountains and drive around, experience the nice weather, and see some of the beautiful colors up there in the mountains. So it's a nice escape for things. And then the winter months, again, we have a couple of snow days. Again, aerial shot of the grounds there. Again, not too much of an inconvenience, but and we have a great infrastructure for sort of clearing the roads in a pretty timely manner as this comes in. But again, it's fun to see, especially I grew up in South Carolina, so seeing a few more snow days a year was kind of exciting. And then obviously as you transition out of winter, seeing all the trees sort of come back to life. So the dogwood trees and the eastern redbud, the the spring foliage really is quite a sight to behold. And again, seeing some of the warmer temperatures is always pretty exciting. But in the summer months, I think there's a lot of really big perks. So this is up in the mountains, Skyline Drive. Again, typically runs about 10 to 12 degrees cooler up in the mountains. So pretty much year round good hiking up there. So the weather is always nice, even when we're peaking out at, again, sort of around 87. It's about 10, 12 degrees cooler up there. So always a nice escape. This is a picture from Carter Mountain, which is one of our apple orchards that sort of overlooks Charlottesville. So you can't really see in this picture, but just beneath the sunset there, off to the right actually is the hospital system. But a lot of people go up here right now, they're doing tickets, so you can go up there. So sort of appropriately social distance, grab a beer and hang out with some friends. And it's a really cool accommodation. And sometimes there's some awesome sunsets up there. Charles Peach Orchard is another place you can get out to. It's about a 30-40 minute drive from Charlottesville, but really cool accommodations throughout the year. So obviously peaches, apples, they do in the fall. They have pumpkins, they also have strawberries and blueberries. So fun to go out there, pick some produce. And again, it's sort of nestled in the foothills of mountains all around. So really nice views out there to take family and kids if you have them. So some of the big time accommodations of Charlottesville are some of the bands that come through. So because this is a college town, there are some really cool bands. So for those of you who don't know, Dave Matthews Band actually got their start sort of playing for the college scene here in Charlottesville, Virginia, before they hit it really big. And they still come through occasionally, but again, we get some good concerts that come through, and also some local bands who play, Fridays after 5 and stuff. But again, this is a sort of aerial shot of one of the concerts at the football stadium. And obviously we have our fair share of collegiate sports as well. So always stuff to do in the warmer months, and obviously football as we transition into the fall. One thing that's awesome, a lot of folks do, is the downtown mall, which is basically used to be a road, but they blocked it off. And so it's just foot traffic through there. There's a ton of bars and really good restaurants and a great night scene to sort of go and unwind and start the weekend off. It's a lot of fun. We run into a lot of our colleagues from Gen Surge and other specialties down there and have a really good time. During the day, it's really nice. As you can kind of see there off on the left, they have outdoor seating for most of the restaurants. And even when it's hot out, the shade from all the poplar trees there really make it a nice climate for pretty much year-round dining out there as long as the weather permits. And then on the weekends as well, usually on Saturday mornings during the summer months, they have an outdoor market. So they have a ton of accommodations from local artists, food. You can try the different food trucks that come through and pick up some produce to cook dinner. And then you can kind of see the outdoor arena there in the top portion of the picture that we saw, and then the poplar trees kind of going down. That's sort of gives you a lay of the land of downtown Charlottesville. But one of my favorite things to do when I have some time off is go up to the mountains. Again, the weather is almost always nice up there to go and do a hike or at least drive around. There's a ton of short and long trails alike. The waterfalls are a lot of fun. You can actually get sort of apps from sort of the hiking trails to either go downhill and see a waterfall or go up to a summit. This is actually a picture of Old Rag, which is one of the most popular hiking trails on the East Coast. And it's about a 9-mile loop, and the sites are certainly worth the hike up, sort of grappling up the rocks. Most of us did this as an intern. It's a heck of a hike. And again, as you get to the top, it's some beautiful views. The last thing in closing, I'll say, I think the thing that really makes Charlottesville awesome is the residencies and the camaraderie that we have within our group and in between our faculty. But I think the residents that, they choose that match here really are sort of like-minded, and that sort of spills over with our significant others. We have a great group that likes to hang out both in and outside the hospital, and a good support system for our loved ones who are obviously going through a big sacrifice through residency. And I'm really thankful to have all these people in my life. And I know my fiance is as well. And so we get together and have a good time. But that being said, if anybody has any questions, I'll sort of open the floor, and you can also ask questions in the small group.
Awesome, Ian. Thank you very much.
Of course.
Does anybody, so I learned a lot about the snow and all that different stuff. Yeah, I will tell you one thing as someone who lives here, when it does snow 1 inch, it does kind of shut the city down. I know that Keith did his residency in Cleveland, and like an inch of snow, they just sneezed at. But here, if it snows an inch, they get the snow plows out, and it's hard to even get to work. But
That's
right.
such a joke,
I know
but it's awesome if
It
you
is.
don't want to go do stuff. But
That's right. It's a
it's
lot of fun.
adorable. It's adorable.
it is adorable. Yeah, I know we've got a lot of Clevelanders and other northern folks. It's hilarious.
Yeah.
So,
Well, I do think that Charlottesville, I think it's a quite temperate climate, so it ends up being a pretty good situation. Yeah, any questions in the group? So I was thinking maybe that what we can do, because Dr. Cooper he's picking up his. Dr. Cooper is the ultimate surgeon / dad / do it all, and he's picking his son up from soccer practice right now. So he's going to have 10 more minutes. So what I'd like to do, if that's okay with you guys, is break up into small groups. We have 6 residents here, so I made 6 rooms, and I hope that some of the residents know they're going to be hosting a small group. Tim Lancaster, are you here? So now it's time to get to the sort of didactic portion of the evening. We have Truitt Cooper, who's our foot and ankle faculty, is going to be joining us. He had to pick his kids up, I think, from soccer, and everyone's dropped off, but now he's in his son's room. I think you should comment on his gaming chair that he's currently sitting in. It's very, very, very sleek. So if you want to look at it, it's pretty sweet. So he's obviously made for this, okay?
It's got like lumbar support and everything.
Good gracious. Oh, to be young.
This is
So
the first time I've had sitting in it.
Dr. Cooper is part of the foot and ankles team, along with Joe Park and Venkat Paramal. All 3 faculty from foot and ankle are here, and I'm gonna give the floor over to Dr. Cooper, who can introduce this division and go from there. Okay, go ahead, Truitt.
Yeah, thank you, Winston. So you get a little insight into my home life with virtual school. My son has this amazing gaming chair, and this room is he's taken it over, and that's where I am. So no, thank you all for being here tonight. We're happy to have you, and we're happy to be here. We have a great division. I mean, we have a great department, but foot and ankle division, obviously, we're really close, and Dr. Park and Dr. Paramal are here as well. And I think I could speak for all of us and say we're all one of the biggest reasons we're at UVA is because we love the residents and we love the residency. And I left private practice after 5 years basically to come back and be a part of education more than almost anything else. So yeah, happy to be here, and hopefully I can give you guys a little information about Achilles ruptures. I think if you're going into orthopedics, you're going to come across Achilles tendon ruptures, or you may know someone who has one, and for all sports, we want to know about it. So I think it's a fun topic. So I'll get started, and I'll be quick. If you guys have questions, interrupt me anytime. I'm going to try to share my screen here. Oh boy.
I'm sure I can help you figure it out. No, you've turned your video off, and I don't see your screen.
That's perfect. There we go. I got it now.
the gaming chair didn't come with instructions.
Only for Fortnite. It's not made for academic purposes. It's made for shooting people on virtually. Can you guys see it now?
See it fine. And all right, man. Go ahead.
Okay, great. So just we're going to talk about acute. This is acute Achilles tendon ruptures. This is different from people with tendonitis and things like that. I don't have any.
Hey, Truitt.
Yes.
Real quick, can you introduce your division?
I did, sort of. We have Dr. Joe Park.
Joe, you here? Can you wave?
He and I both went to medical school at UVA.
Yep.
And he trained at HSS, or not.
Joint disease.
Yeah, joint disease, sorry, New York City. And then did his fellowship in Baltimore. Dr. Paramal did his fellowship at UVA and has been here for 7 years, I think. But yeah, we're all integral in the residency and play, that's a big part of our careers and our life. And so they're here. So please feel free to ask us any questions. All right. So I'm just going to talk about Achilles. I'm going to go through this quickly. There's a lot you could discuss about Achilles tendon ruptures. They're common. They're constantly changing how we treat them, but it's an interesting topic, and I think something that most of you would encounter at some point in your career. So who gets Achilles tendon ruptures? So really, the rate is about 9 to 55. That seems like a broad range, but it's a lot of different studies per 100,000 per year. And it's increasing. It's most commonly associated with sports. Males are much more common than females, anywhere from 75 to 90%, depending on the studies. And I think that's pretty accurate in my practice. Most commonly between the age of 31 and 51, but I see people younger and younger. I saw a 17-year-old female with an Achilles rupture last year, and that was probably the youngest female I'd seen in my career. But we're also seeing older patients as I think America's population is staying active longer and participating in sports like pickleball and things like that, and well into their 60s, 70s, and even 80s. So how do we get here? So there's a lot of controversy about Achilles tendon ruptures in some ways. Back before I was a resident and in the 90s, it was basically felt that if you ruptured your Achilles tendon, you had to have surgery. It was like a no-brainer when I was a resident. There was no debate about it. You had to have surgery. And the reason why is because some of these early studies from the 90s showed really high re-rupture rates with people that did not have surgery. This big study showed a 12% re-rupture rate. Other studies showed between 8 and almost 40% re-rupture rate with non-operative treatment. The reason why is they were treating them all with cast. If you didn't have surgery, you got a cast for 12 weeks, non-weight bearing. And we know that tendons don't heal very well that way. Well, in 2002, Bandari, who's like the meta-analysis guru of all of orthopedics out of Canada, did a huge meta-analysis on Achilles tendon ruptures and found that there was a pretty significant decrease in relative risk of re-rupture in favor of operative treatment. But when you looked at the study, most of those studies that he included were from the 80s, 90s, and early 2000s, and they all included cast immobilization. And so this became the gold standard. If you had Achilles rupture, you got surgery. So what are the questions? Operative or non-operative treatment? If surgery, is it open or minimally invasive? What's the best post-operative protocol? In 2010, which doesn't seem that long ago, but I guess now as I get older, it's actually 10 years ago. So to you guys, it might seem like a really long time ago. The American Association of Orthopedic Surgery put out a clinical guideline about Achilles tendon ruptures and how to treat them. And initially, when this was sent out for review, the only recommendation they had was for percutaneous over open repair. That was it. They said percutaneous is better than open. And there was a lot of outcry because nobody was doing percutaneous repairs at that time. And so people said, you can't publish this. This is a disaster. And so they removed it. But what they did report was that, number one, that a history and physical exams should be performed. Of course, right? That's like the only consensus thing they had. And they said it was in the absence of reliable evidence. Unable to recommend for or against advanced imaging. Non-surgical treatment's an option. Grade was weak. Unable to recommend for or against functional bracing for non-operative treatment, and that surgical treatment's an option, and the grade was weak. So, even in 2010, there wasn't a lot of great evidence to really truly guide us on what we should do with Achilles tendon ruptures, even though it's a common injury and something we sort of take for granted. They did say that you should approach surgery with caution in patients with a lot of risk factors. Additionally, that open, limited, and percutaneous techniques are options. Again, this is weak evidence. And that you can't recommend for or against augmentation. I think a lot of the literature since then has said that you don't really need to augment these repairs. And what they meant by augmentation was doing tendon transfers, collagen scaffold grafts, things like that. And they didn't have any evidence for or against DVT prophylaxis. We'll talk a little more about that. Additionally, what they did report was they said that early weight bearing is better, and a bunch of other non-conclusions. And so later that year, like less than a year later, a big study came out in the JBJS actually, and this was really the first. I think this was a groundbreaking study. And it was the first big study that supported non-operative treatment, and this was done at the University of Utah as well as Ontario and a couple other centers in Canada. They had 144 patients. They randomized them to functional immobilization or surgery, and the key thing was functional immobilization. They didn't cast them for 12 weeks. They splinted them for 2 weeks and then transitioned them to a removable brace and let them bear weight early. And they evaluated the rate of re-rupture, their strength, their range of motion, and they followed them for 2 years. So this is a great study, and I think it's really helped guide us on Achilles tendon ruptures in some ways. And what they found was that the re-rupture rate was about the same for operative or non-operative, and this was the first study to show that. And the key thing is that it was, again, functional bracing. So we know that, and what you guys will learn through your careers is that tendons don't heal well without a little bit of stress. And so it's always a fine line between stressing the tendon enough to make the collagen heal in a normal fashion so that it's strong when it's done versus over lengthening or stretching out. They didn't find any real difference in range of motion, strength, calf circumference. they did find increased complications in the operative group, which is not surprising. It was all soft tissue complications and small wound complications and things like that. Another study out of New Zealand found similar results, but they found that males perhaps needed surgery more often than females. And then another study out of Europe showed that, Great Britain showed that non-operative treatment is a possibility if you use functional bracing. And so this really changed things. We'll skip those. I think where we are now, as far as surgery or not surgery, there's still a slightly higher risk of re-rupture in non-surgical management. It's probably somewhere between 5 and 8%. It's probably higher in young active males. I think the bigger issue is a little bit of elongation of the Achilles that happens with non-surgical treatment. And so they may get a little bit of weakness at certain speeds of strength. Additionally, I think surgery is a little bit more forgiving. If you repair the tendon with sutures and the patient takes their brace off and does something stupid, then they have a better chance that it's not going to just come apart. Older patients, I do think there may be a role, again, of female patients, and we don't know if that's because of compliance or just absolute strength. It may do equally as well with non-operative treatment. But in America today, we still lean towards surgical treatment for young active patients. So then you go to the question of open versus minimally invasive. And so over the last 15 years, I think there's been a really significant increase in interest in these minimally invasive percutaneous techniques. And some of it's driven by industry, but a lot of it's driven by evidence, actually. What are the potential benefits of minimally invasive treatment? Primarily, it has to do with the wound. With traditional Achilles surgery, you make about an 8 to 10 centimeter incision over the back of the heel, and that skin, just like the Achilles, has sort of a delicate blood supply, and there's a high risk of wound complications and things like that. With minimally invasive techniques, you can really decrease these wound complications, and I think you can move them faster, because the reason we have to slow them down is to decrease wound problems. Potential downside? Well, with the truly percutaneous techniques, I think there's a high learning curve and there's a risk of sural nerve injury, although there's some studies that describe how to avoid that. You can get puckering of the skin if the suture kind of grabs the skin on its way in. And in cases where it's maybe a little bit delayed, it's probably more difficult to oppose the ends of the tendon. And that's what you need to do, is restore that tension. This is probably the best study on minimally invasive techniques, and it was done by Keller in 2014 in the American Journal of Sports Medicine. It was a 42-month follow-up with 100 patients. They treated them all with their minimally invasive technique, and they had people back to work, at 56 days. That's amazing. And back to sports at about 18.9 weeks, which I think is pretty fast. Overall, they did well, and importantly, they didn't have any sural nerve injuries. They had a really low re-rupture rate, and they had great strength. And so I think that's showing that from a strength standpoint and re-rupture rate, it's equivalent to the prior open repairs without any significant complication. Meta-analysis done by Mafuli et al. Out of Italy found better ankle function and lower complication rate with the minimally invasive group. And so I think that the conclusion from this is that both are acceptable if used appropriately. Our trend has been towards minimally invasive. I think there's lower wound complications. Patients like it. There's less scarring. I think the scar is actually a big deal with Achilles, especially in high-level athletes. That tendon, if you don't get a good repair of the peritoneum, which is that tissue around the tendon, tends to scar to the skin, and so they'll get these weird adhesions, and that bothers people cosmetically. We often say that's not a big deal, but it matters a little bit, and less scar complication, tenderness around the scar. And without worrying about the wound healing issues, you can rehab them a little earlier, start them moving. And so I'll describe our technique, I think here we all do it the same way. I don't do a percutaneous technique. For me, it's more of a minimally invasive technique. If there's somebody that presents delayed, maybe they're 3 to 4 weeks out from their injury, I will do still a formal open repair, because I think the Achilles is amazing in its ability to heal. It's not that if we don't fix these things, they won't heal. It heals really well. So if you don't, it's just that they heal with elongated and with not appropriate tension. So it's like slack in the pulley. But what we find in 3 to 4 weeks, that scar tissue is already formed in between the two ends. And with the minimally invasive techniques, you can't remove that. So I'll do an open one there. But for most Achilles tendon repairs at this point, I do a percutaneous repair, or minimally invasive repair, more technically. And this is the technique. I Unlike this diagram, which was taken from Arthrex, I use a longitudinal incision rather than horizontal. The reasons for that are that I think if you don't center the horizontal incision perfectly, you can't get to the end of the tendon very well. And secondly, if something is, surprising, where maybe there is more scar tissue interposed or something unusual, it's harder to extend that incision. So I'll use a longitudinal vertical incision, about 3 centimeters or so, centered over the proximal stump of the Achilles. I pull it out, I put my sutures in that proximal stump, and then I'll anchor it, just like it's shown here, to the calcaneus with 2 suture anchors. And I think realistically, the distal portion of the Achilles tendon is sort of a fixed length, so it's not going to contract really. What you really need to do is restore the tension between the gastroc and soleus muscles to the calcaneus. That's all the Achilles does, is you have to restore that length from the gastroc soleus complex to the calcaneus. And by pulling it down, you avoid a lot of issues with bunching up at the tendon ends. The suture knots are not directly under the skin incision. So this has been a great change for me over the last probably 4 to 5 years. I've had better results, less scar issues, no wound problems, and I feel like it's a really solid repair. Pearls, tips, I try to make it as tight as possible. They all stretch out, operative, non-operative, between sort of 4 to 8 weeks, around there. They all stretch out no matter what you do. Even if you put them in a cast, it's still elongated. Somebody did a really nice study where they put radiolucent markers in the Achilles tendon, x-rayed them at different time points, and they found that even if they casted them, they still lengthened. So I make it as tight as possible to start, and I've not had anybody not be able to stretch out. Post-operative rehab, it's not as controversial today. Everything currently supports early weight bearing and rehab. A great study by Zellers et al. They looked at 150 different publications, systematic review. And the interesting about this is they looked at only studies that described an early functional rehab. And what they found was there's really no standardization of what early rehab means. But the truth is that really after about 2 weeks, you want to get these people moving. You want to limit the dorsiflexion to neutral. You don't want it to stretch out any more than it's already going to. You can bear them. You can bear weight early, in a boot with heel lifts to prevent that dorsiflexion. And if you move them earlier, get them weight bearing, I do think that the collagen returns to normal more so than if you immobilize them for a long period of time. And in this study by Huang et al. Found that there was really no increase in re-rupture rate. And, a lot of this depends on patient compliance. I mean, we hear about professional athletes and they fall off their knee scooter, they re-rupture their Achilles, or something happens, they re-rupture their Achilles. I mean, things like that are going to happen whether you treat them operatively or not. And it, bad luck happens, but overall in the standard population, there's no increase in re-rupture rate. Another study looked at early weight bearing versus delayed, and they really had improved outcomes at 6 months, but not much difference at a year. You do want to limit, like I said, that range of motion early on. You want to limit them to like maybe minus 10 degrees of dorsiflexion, so don't even let them come up to neutral, certainly not past neutral, because that greatest lengthening comes between 2 and 6 weeks as the tendon's at its weakest point. So goals, you want to protect the tendon during healing. You want to apply some early stress to enhance healing and normalization of that collagen structure. You want to limit the gastroc soleus atrophy, and most people will be able to get that back regardless. And you want to return to normal function as soon as possible. Avoid overlengthening. So this is what you don't want to see. That patient on the left, it's like, oh, wow, they have great flexibility. No, they have a weak gastroc soleus complex. They're never going to be able to jump off that foot. They're never going to be able to push off it. So you don't want it to be overlengthened. Return to sports, most will be able to. It's rarely before 6 months, and I tell my patients, if they're not a high-level athlete, I tell them, like, look, you're like me. If I rupture my Achilles tendon again, my wife would kill me. I've got to work. I don't need to go back and play basketball. Give it 8, 9, 10 months, a year. For the high-level athletes, they want to push it. You hear stories about NBA players or NFL players come back at like 4 to 6 months. I think that's highly risky, and I wouldn't recommend it. Kevin Durant's sort of more of a typical story. I mean, he's been out well over a year. He probably could have come back in the playoffs this year, in my opinion, but it's not worth it, because in addition to chance of re-injuring the Achilles, you re-injure other things. Kobe Bryant came back from his Achilles and got a tibial plateau stress fracture, I believe. So, it takes a long time to rehab that sort of neuromuscular function to not have those other injuries. There's a recent study of college football players, and they said 90% of them were able to return to participation. But the interesting thing is much fewer made it to the NFL compared to controls. So Achilles tendon injury, you can come back and participate at a high level, but that elite group, if you lose 1%, that's the difference between going to the NFL and not. Future controversies, PRP, biologics, there's been a lot of talk about those kind of things, whether you augment things with PRP or stem cell injections. There's not really any data at all to support that. Same with other growth factors. In the past, people were looking at collagen scaffolds and xenografts to augment these repairs. That's not borne out and not necessary. Fiber glue and things like that. None of that's ever been proven. I think if you get a really good primary repair, the goal is to get people back, and you don't necessarily need all these extra things for Achilles tendons because they want to heal. I know that was a lot. It was quick. I want to get through it and take some questions.
That was great, Truitt. Appreciate it. I think David actually has a case you might want to show. David, you got a case?
Yeah, and we can hit some of the topics as we go. I just want to give you guys pretty bread and butter case and a chance to interact here. So
We're going to try the polling feature, see if it works. So hopefully you guys can figure out how to use it.
All right. So you have a 34-year-old male who walks into your clinic. He's got a left leg injury. He was playing basketball a couple days ago. Felt like someone kicked him from behind. So he looked back, had pain, issues with his left leg. So he went to the emergency department. He was splinted and then referred to your clinic. He came with x-rays from the emergency department, which were read as normal. So he's there, you got him on the table, and you examine his calf. It's the left calf. That's what it looks like. He's got a palpable defect, maybe 5 centimeters proximal to the Achilles insertion. And then your next step is you do this. You look at the uninjured right leg and the injured left leg.
Anybody tell me what the sign's called?
Thompson sign.
There you go.
Great. What are you looking for here? What are you doing with the Thompson test?
You're squeezing the calf and you expect the foot to plantar flex.
Good.
Because of an intact Achilles.
Good. So as you can see on the right leg, that's happening. On the left leg, he's basically got no plantar flexion. So it's an Achilles rupture because this is a talk about Achilles ruptures. So what else do you want to know from the history and the physical exam?
The hand raise feature, what do you want to do?
That would be great.
Anybody else has a comment?
Just that 34 is very, very young.
It's
Are you
really
just
smart.
saying in relation to us, or just like?
Yep, exactly. Anyone within 10 years of my age is considered very young.
You're an old man now.
Yep.
So Dr. Wathman, I can't see if people are raising their hands, I can't see it.
I don't see any hands raised.
Okay.
Who has a hand raised? Let me know. Oh, wait.
There's
James,
some people commenting. There's some comments coming in. So
There are a lot of questions, like in the chat box. Is he an athlete? Mechanism of injury? Level of function?
Oh, here we go. All right, great. Yeah, I agree with all those. Some other things that I want to know. Did he have antecedent pain? We didn't talk about chronic Achilles issues, but that might change the pathology. His functional status and goals, whether or not he's a smoker, I'm probably thinking about, we're going to have a conversation about surgery. And so along with that, comorbidities as well. There's an antibiotic association with this. They teach you in medical school. Who can tell me what that is?
All right, hands raised. All right, let's see. I got Clark.
That's the fluoroquinolone.
Great. And then you want to get a good neurovascular exam, know if they're neuropathic, know if you're going to have a conversation about wound healing issues as well. So in summary, right now,
Can I interrupt you for 1 second?
Absolutely, please.
two of your things. So two things you mentioned is antecedent pain. I didn't talk about that, but I think it's a really important point. Most of these acute Achilles tendon ruptures in young athletes, they don't have a lot of tendinopathy, and so, but if somebody said, yeah, it's been hurting for 2 years and now this popped, that's a different story, and I think it needs more investigating. The other thing is corticosteroid injections. We've seen this a number of times where people have had, this retrocalcaneal bursa injection. So there's a bursa between the Achilles and the calcaneus, and some athletes will get inflammation there, and they'll do this injection there thinking, well, we're not really injecting the tendon. I still think that's a really bad idea in an athlete, because we've seen a couple disasters where, maybe they put it in that bursa, but later, it leaks up and the tendon then ruptures, and that's a different repair. That tendon is just destroyed. It's not healthy, and it doesn't go well. So those are important points.
Awesome. I'm loving your guys' interaction on the chat. That's great. All right. So in summary right now, we've got a young, healthy, active male. He had a basketball injury. He's got a palpable gap at the mid-substance of the left Achilles, positive Thompson test. He's got, also has increased passive dorsiflexion and weak plantar flexion. So, Dr. Gwathmey, are we able to pull?
What we'll do is ultrasound is A, MRI is B, non-op is C, and surgery is D. So let's see if this works. So you guys click on this, and I'll be able to share it here in a second. You guys can see the poll. All right, I'm getting some answers. When I get to here you go. Don't worry, I can't tell who's answered what. So when everybody is answering non-op management, needs to go to PM&R residency instead. I'm just kidding. All right, we have a quorum. Ending polling. Ready for me to share results? All right.
Okay, great.
So, only the three of you who said non-op to go ahead and let me know, okay?
Hey, David, can I interrupt you for a minute?
Please, I'd love to hear from you.
So the Achilles tendon injury is a clinical diagnosis. You don't need anything else, ultrasound or MRI, to diagnose an acute Achilles injury. It's mostly a clinical diagnosis, and imaging is not necessary at all, right? So you palpate the Achilles tendon, you feel the gap, and the Thompson's test is positive. That's all you need. Sometimes, if you have a antecedent pain in the Achilles tendon, then that is the time, you get an MRI to see what is going on with the tendon pathology, anything else going on, so that you can get an operative, you get a good feel of the tendon, what is available for your surgery. But for all other purposes, actually, it's a clinical diagnosis.
Dr. Cooper, Dr. Park.
There was a good study that showed that the only effect MRI had on Achilles tendon ruptures was that it delayed management, didn't change management, just delayed it by a week. I only, if I have like a 60-year-old patient with a more proximal pain, I'll sometimes get one just to prove that it's really at the myotendinous junction. But otherwise, I don't think there's much of a role for MRI in these. I think ultrasound's fine if you have it available just in your office, and you can do it at the same time if you just want to prove it. I think if you have somebody, I think one role of ultrasound may be in the non-operative patients that's like sort of borderline. Like, so for non-operative patients, we generally want to get them in a splint and plantar flexion within a couple of days. Let's say somebody shows up in a week. I think if you have an ultrasound available and you can do that in plantar flexion and see if the ends approximate, I think that could be of some benefit. It's not been really proven, but that's sort of my feeling on it.
For me, I think I always do get an X-ray. I had a case of a 20-something-year-old person who had an enormous ostrigonum, actually, that was very sharp, and it was weird, but his rupture was right at the level of that very large ostrigonum, which I've never seen before. But I do, and as Truitt said before, sometimes these guys have, I've had about 3 cases where they had a very large Haglund's deformity that I think was, caused some of the irritation. So in those cases, I did take the Haglund's down at the same time.
Mm-hmm. Mm-hmm. Great. Dr. Park, do you have any comments about how you guide that conversation about just in general for this healthy male, non-operative management versus surgery?
Yeah, I think you have to get a sense of their ability to be compliant. So in this vignette that you suggested, let's say he's 34, but he weighs 280 pounds, right? That's not a guy that's going to be able to protect that left leg. I very much agree with Truitt. I think early range of motion, early weight bearing. I am a fan of early range of motion and delayed weight bearing. I let them aggressively move the ankle, but I don't trust my patients all the time, and I worry about the wound. So I always wait until about 3 weeks to let them really aggressively move, just because if that wound breaks down, it's a huge setback. And then, yeah, so I call that sort of the knucklehead factor, evaluating for that. And, obviously, if you treat them non-operatively and they're a knucklehead, you can always do something later. But if they re-rupture and get some kind of crazy infection, that can obviously be catastrophic.
By the way, I was kidding about the non-op stuff. Yeah, our thing. Sorry.
Another thing, David, if you're really talking about a non-op management, the functional rehab protocols, it has to be within a week. There are pretty good studies shows that, you have to get them early to do the non-op treatment. If it's like 2 weeks, 3 weeks old, definitely the non-op treatment is not going to work.
So just for the sake of this talk, I found in the radiology literature some images. We don't like they said, we don't routinely get ultrasound or MRI for these, and I'm no expert at reading these ultrasounds. This is what an Achilles rupture would look like on ultrasound, and then MRI as well. You can see the normal tendon on the left, and then you see a gap and a rupture on the right. So this patient was taken for surgery. Like Dr. Cooper had talked about, there are different techniques that have been described. This is not great images of an open repair, but it does lend us an opportunity to talk a little bit about the anatomy. So let's say you open up, you make your incision and you've got a picture that looks like this in the operating room. So you see that some structure that is on the medial side of the leg. Does anyone have an idea of what that might be? It's intact. It's right next to this Achilles tendon rupture.
Be back.
Is that the plantaris?
Good, great. Yeah, that's the plantaris. So there's another structure that we try not to get when we're doing this during the surgery. Can anyone tell me what that is? Looks like we're getting some chat answers.
Nick.
Yeah, sural nerve.
Sural nerve, good. Yeah, great. So that's the plantaris there. Remember, sural is going to be, if anything, a little on the lateral side. If just remember the distribution of the sural nerve is going to be on the lateral side of the foot. So I think one of these pictures might have been from the same paper that Dr. Cooper presented. This was just a little more information about how and what we've done with Dr. Cooper and done with one with Dr. Paramal as well. So like he was saying, small incision, kind of that minimal invasive approach, get the proximal stump out after you carefully dissect that peritoneum. And then you're preparing the tendon to tension it down to the calcaneus, and we use suture anchors in this case. I think they're using different anchors, but like Dr. Cooper said, the goal of this is to get your tension back in the Achilles, and so that is their repair. And then you want to ensure when you're closing this wound that you have a good closure, just because of what we talked about with wound complications.
That is so sporty, guys. It's awesome.
So, David, one more thing, minimally invasive, like a mini incision, you can go right in the posterior or right in the middle incision. But if you happen to get a little bit older injury, like 3 weeks old injury or 2 weeks old injury, if you want to open, do an open technique, I tend to put my incision more on the little bit of medial side of the tendon, because of the lateral peroneal artery, which is main supply of the skin, as well as the peritoneum of the tendon. So try to protect the vascularity of the skin as well as the peritoneum and then the tendon. So when I do an open approach, I usually put my incision a little bit more medial in the tendon rather than just go straight in the back.
It's crazy. I never did a single one of these in residency like this. It's amazing how it's evolved. For when I was a resident, it was all open, big open incision.
Even I never did a single one like this in a residency. That wasn't long ago. We did them all open.
Cool, man. All right. You got anything more, David? We're kind of
That's it. Yeah.
it's against the clock here. That
Yeah.
was really cool.
Good, thank you.
Man. Well, do you guys have any other questions? I think we can wrap it up at this point. Foot and ankle team, you guys did a great job. So I hope all y'all were able to interface with the residents in the rooms that you're in. They did share their email addresses on the chat. If you need to get in touch with one, you can always email me and I can give you contact information as well. But thanks a lot for showing up. I will say that I am putting together, there's a Google Doc sign up for if you want to chat with me or Dr. Bachman at some point. I added another date on October 29th. If there's people who did not get to sign up when they wanted to sign up, you're welcome to just change into that date too, okay? Otherwise, we're going to wrap it up tonight, okay?
Right. Thanks,
again,
thanks, David.
Huge, it's Roanoke. It's going to be a great conversation with Dr. Schuler about the Roanoke experience, okay? So
Thanks,
thank you, Dr. Cooper, Dr. Park, Dr. Paramall, David, Ian, you guys did great. Thanks, guys.
Thank you, guys.
Thank you.
Thanks a lot, guys.